Welcome to the Deep Dive.
I'm happy to be here.
Today, we're really zeroing in on aortoiliac aneurysms.
Yeah, with a particular focus on abdominal aortic aneurysms, or AAAs.
And our guide for this is, well, it's the latest Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
That's right, a fantastic resource. So, should we start with the basics? What is an aneurysm?
Good idea.
Well, fundamentally, it's when an artery bulges out. The definition says it's an increase in diameter 1.5 times the normal size.
And it involves all three layers of the artery wall.
Correct, all three layers.
Yeah.
Specifically for the infra-renal aorta, below the kidneys, we usually define it as being wider than 3 centimeters, or again, that 50% larger figure compared to a normal section nearby.
It's kind of amazing this isn't some modern discovery.
Not at all.
Our sources mention the ancient Egyptians knew about these way back, like 1550 BCE.
It's incredible, isn't it? And then the first real attempt at treatment centuries later was by Antyllus.
Right, he tried ligation, tying them up.
He did, but the outcomes weren't great back then, as you can imagine.
Really shows how far we've come.
Absolutely. The 20th century saw huge strides with open surgery.
Like reinforcing the artery. Or rebuilding it.
Exactly. Using the patient's own tissue sometimes, or synthetic grafts. Think DeBakey and Cooley in the 50s, their work was pivotal.
Changed the game for managing it.
Definitely improved outcomes. But then the real revolution, as you called it.
The endovascular approach.
Yes. Juan Perotti's work in the 90s with the first endovascular stent graft for an infra-renal AAA.
And the FDA approval followed pretty quickly. 1999.
That's right. And since then, endovascular techniques have really taken over.
They're the main approach now for planned and emergency cases.
Largely, yes. Especially for elective repairs, it's often the first choice over open surgery these days.
Okay. So our mission today is to really unpack all this, pull out the key info on these aneurysms.
Yeah, like how common they are, the risks, how we find them.
And how we manage them now. Let's maybe circle back to that definition first. Some nuances there.
Right. So infra-renal aorta, greater than 3 centimeters or 50% larger, we've got that. But the interesting thing is how we got that normal size. It was originally based on studies of, well, mostly older Caucasian subjects, around 70 years old.
So not necessarily representative of everyone.
Exactly. We know there are variations by sex, by race.
So should the 3 centimeter definition change depending on the person?
Well, people looked into that. The ADAMS study, that's the Aneurysm Detection and Management Study, they concluded that, yeah, there are average differences, but maybe not enough to warrant changing that basic 3 centimeter definition for aneurysm.
So it's still a useful benchmark for everyone. Keeps things consistent.
Pretty much. Yeah.
And the source also distinguishes true aneurysms from pseudo-aneurysms.
Yeah.
And penetrating ulcers.
Right, good point. A true aneurysm involves all 3 wall layers stretching out.
Okay.
A pseudoaneurysm is different. It's more like a contained rupture, maybe after an injury. The blood is held back by just the outer layers or scar tissue, not the whole wall bulging.
Got it. And the penetrating ulcer.
That's where there's an erosion, usually from plaque, digging into the wall, through the inner layers. Doesn't necessarily cause that big bulge like a true aneurysm. Different mechanisms.
Makes sense. So focusing back on the true aneurysms, these bulges, where do they usually show up?
They can happen anywhere along the aorta, but the infra-renal section is the most common spot. About 30% of all aortic aneurysms are found there.
And how do we know who gets them? It's not just from regular checkups, is it?
No, usually no. A lot of our data comes from, well, autopsy studies historically, and more recently from targeted screening programs, looking at groups considered high risk, mainly based on age and sex.
So what do those studies tell us? How common are AAAs in the U.S.?
The prevalence is around 1.4% for people aged 50 to 84, using that 3 centimeter definition.
1.4%. Doesn't sound huge, but it's definitely not insignificant. And age is a big driver.
Oh, absolutely. It's considered the single most significant risk factor. The odds just climb steeply with age.
Like how steeply?
Okay, so compared to younger folks, if you're 65 to 69, your odds are about 5.4 times higher.
Wow.
But then get to 75 to 79, it jumps to 14.5 times higher.
A massive increase. What else? You mentioned Caucasian race and male sex.
Yes, those are also well-established risk factors, though it's interesting. For women, the incidence tends to peak later in life compared to men.
Now, thinking about things people can actually change, modifiable risks. One stands out in the notes.
Smoking. No question. It's definitively the biggest modifiable risk factor for developing in AAA.
And it's linked to how much you smoke.
Absolutely.
Yeah.
It's dose-dependent and duration-dependent. Even smoking less than half a pack a day for 10 years boosts your risk.
And heavy smokers.
If you've smoked more than a pack a day for over 35 years, your risk could be like 12 times higher. It's dramatic.
12 times.
Yeah.
That's incredible. It's good news, then, that as smoking rates have fallen in the U.S.
So has the prevalence of aneurysms. Yes, it really drives home the impact of quitting.
Any other major risks? Family history.
Yes, that's important too. Having a first-degree relative, parent, sibling, child within AAA increases your own risk by about 20%. There's a definite genetic link.
20%. Okay. What about other things? Diet. Other conditions?
There are weaker associations. Things like higher salt intake, atherosclerosis, history of heart attack, peripheral artery disease, stroke, high blood pressure.
Kind of the usual suspects for vascular issues.
Pretty much. On the flip side, things associated with lower risk include being female, African-American race, and having diabetes.
Diabetes lowers the risk. That's interesting.
It is, yeah. We also see a link with COPD. Somewhere between 7 and 11% of people with COPD also have in AAA.
So, quite a few connections.
Yeah.
But the main controllable things are smoking.
Smoking cessation is key. And then managing diabetes, if you have it, good diet, exercise, those general healthy lifestyle things help reduce overall cardiovascular risk, which ties in.
Right. Now, let's talk about associated aneurysms. AAAs don't always happen in isolation.
That's right. When someone has an infra-renal AAA, the problem can often extend. Well, in maybe 5% to 15% of cases, it goes up higher, involving the aorta near the kidneys, the juxta or suprarenal aorta.
Yeah.
And quite often, maybe 10% to 25% of the time, it involves the iliac arteries too, down in the pelvis.
And connections to aneurysms elsewhere in the body.
Yes, definitely. About 12% of people with AAAs also have one in their thoracic aorta.
Higher up in the chest.
Right. And around 14% of men with AAAs will also have one in the leg arteries, femoral or popliteal.
And the reverse is even stronger.
It is. If you have a popliteal aneurysm, there's a 62% chance you also have in AAA. If you have a femoral aneurysm, it's 85%.
Wow. That really suggests a systemic weakness in some people's arteries.
It does point towards a more generalized vascular disease process in those individuals.
You mentioned the iliac arteries specifically. Let's dive into those AAAs a bit.
Okay, so iliac artery aneurysms. Most common location is the common iliac artery, about 70% of them.
And usually found along with in AAA.
Very often, yes. The big studies show something like 86% of common iliac aneurysms are in people who have or had in AAA.
So finding one just on its own, an isolated IAA, is less common.
Much less common. Maybe only about 6.4% of patients have just a common iliac aneurysm without in AAA. And about a quarter of those are bilateral on both sides.
And the internal iliacs.
Even rarer, maybe 0.04% of all aortoiliac aneurysms.
And the size definition is similar to the aorta, just scaled down.
Exactly. Same 1.5 times normal diameter rule. For the common and external iliacs, that generally means bigger than 1.85 centimeters in men or 1.5 centimeters in women.
What causes these? Same as AAAs.
Mostly degenerative, yes, similar processes, but trauma can play a role too, penetrating injuries or even surgical injury in the pelvis.
Okay.
And then there are links to certain vasculitides, inflammatory vessel diseases like Behçet's, FMD, Takayasu, some connective tissue disorders too.
And infection. Mycotic aneurysms.
Very rarely, yes. Mycotic IAAs caused by bacterial infection can happen.
So a slightly wider range of causes, perhaps? What about how they behave over time, especially the isolated ones?
Well, the natural history, particularly for isolated common iliacs, is still being fully mapped out.
But we have some data.
Yeah, the Mayo Clinic data suggests a median growth rate of about 0.29 centimeters per year for the common iliacs. And importantly, they didn't see any ruptures below 3.8 centimeters in their series.
Okay. And the internal iliacs.
They're often quite large when found, probably because they're tucked away deep in the pelvis.
So no symptoms until they get big.
Right. They often don't cause trouble until they start compressing nearby structures, nerves, bladder, bowels.
What kind of sizes are we talking then?
Well, asymptomatic ones found by chance average around 5.1 centimeters.
Wow.
If they're symptomatic but not ruptured, the average is 7.6 centimeters. And if they've ruptured, the average size is 8.3 centimeters.
So they can get really massive before they burst or cause symptoms?
They certainly can.
Okay, size is clearly crucial. Let's transition to the big danger. rupture risk.
Absolutely. This is the primary concern, and as we've hinted, it's mainly stratified by diameter.
The bigger it is, the higher the risk.
Exactly. For AAAs under 4 centimeters, the risk over 12 months is generally pretty low, less than 2%.
But it ramps up.
It ramps up significantly once you get over 5 centimeters. That's really the threshold where concern increases dramatically.
Can you give us some numbers for those larger sizes?
Sure. For 5.0 to 5.9 centimeters, the 12-month risk is estimated somewhere between 1% and 11%. It's a range.
Cool.
For 6.0 to 6.9 centimeters, it jumps to maybe 11% to 22%.
That's a serious risk.
And over 7 centimeters, we're looking at over 30% risk within a year.
Those are really stark figures. It's not just size, though, is it? Other factors influence rupture.
Correct. The UK small aneurysm study found other independent predictors.
Like what?
Being female was one, having a larger initial diameter when first diagnosed, continuing to smoke.
Smoking again.
Always smoking. Also lower lung function, FEV1, and higher mean arterial pressure.
Interestingly, not age or BMI in that study.
No, those weren't directly associated with rupture risk in that specific analysis.
You mentioned being female increases risk. How much?
Significantly, women with AAAs seem to have about a 3-fold higher risk of rupture compared to men with aneurysms at the same size.
3 times. That's a critical difference.
It really is. Highlights why we need gender-specific considerations in management.
Are there things people can do to decrease the rupture risk besides surgery?
Yes. The 2 main modifiable factors are good blood pressure control.
Managing hypertension.
Right. And, crucially, stopping smoking. Even if you already have an aneurysm, quitting makes a difference to rupture risk.
That's vital information. What about the aneurysm's characteristics? Does the shape matter?
It does. Saccular aneurysms, those sort of blob-like outpouchings, tend to have a higher rupture risk than the more symmetrical, spindle-shaped fusiform ones.
Why is that?
Probably due to higher, more concentrated stress on the wall in those irregular shapes.
And can imaging show other warning signs?
Yes. Things like a dissection, a tear within the wall, or the amount of mural thrombus, that clot lining, or even certain patterns of calcification in the sac can suggest increased risk.
Where do they tend to rupture most often?
Studies suggest the most common spot is the middle third of the aneurysm, usually right where it's widest.
Okay. Now, they grow over time. How fast, typically?
Yeah.
And can we measure that reliably?
Growth rate is important, yeah. But measuring it, especially with ultrasound, can have some variability, operator dependent.
Right.
One study suggested you need to see a change of more than, say, 0.78 centimeters to be confident it's real growth and not just measurement variation.
So what's the average rate?
On average, AAAs seem to grow about 2.2 millimeters per year. Doesn't seem to differ much between men and women.
But some things make them grow faster. Or slower.
Yes, smoking speeds it up. Having a larger aneurysm to begin with also tends to mean faster growth.
And slower.
Diabetes, interestingly, seems to be associated with slower growth.
And is there a growth rate that triggers intervention?
Generally, growing 10 millimeters, that's 1 centimeter or more within a year, is often considered an indication to intervene.
It's encouraging, though, that despite all this, overall deaths from AAA rupture are actually going down, at least in some places.
It is a positive trend, yeah. Likely due to several factors combined.
Like less smoking?
Definitely. Lower smoking rates, also increased awareness, so earlier detection through screening.
Better treatments, too.
Improve outcomes from both open and endovascular repair, absolutely. And just generally better cardiovascular health management overall.
And this trend isn't universal.
No, in countries where smoking rates haven't declined, aneurysm mortality is actually still rising, really highlights the public health aspect.
Okay, let's shift focus now to inside the aneurysm. What's actually going wrong? The pathophysiology.
Right. So we need to think about the aorta structure. 3 layers. Intima, media, adventitia.
Inner, middle, outer.
Exactly. The intima is just endothelial cells. The media is the main structural layer, smooth muscle cells, elastin, collagen. The adventitia is the tough outer connective tissue.
And there are differences along the aorta itself.
Yes, crucial differences. The smooth muscle cells in the thoracic aorta, higher up, actually come from a different embryonic source than those in the abdominal aorta.
Really?
Yeah. Neural crust versus mesoderm. And they respond differently to certain growth factors and cytokines.
So they're inherently different from the start. What about the wall structure?
Big differences there, too. The thoracic aorta media has way more lamellar units, those layers of elastin and muscle, and it has its own blood supply, the vasa vasorum, feeding the outer parts.
And the abdominal aorta?
Fewer lamellar units. And it's largely avascular, relies on diffusion from the blood flowing through it for oxygen and nutrients.
Which might make it more vulnerable.
That's the thinking, yes. Less robust, perhaps more susceptible to injury or degeneration.
So what kicks off the degeneration process?
Inflammation seems to be absolutely central. We see higher levels of inflammatory markers in the blood of people with AAAs, things like C-reactive protein, white blood cells.
Can we use those markers to diagnose or predict risk?
Not yet, unfortunately. They correlate somewhat with size, but they're not specific or reliable enough for clinical use right now. They tell us inflammation is happening, but not much more.
So what is happening in the tissue?
The hallmark is the thinning of that middle layer, the media. Through destruction of smooth muscle cells and elastin, you get infiltration by inflammatory cells, new blood vessels forming where they shouldn't, neovascularization and deposition of collagen trying to patch things up, but it's not the same.
And that clot, the intramural thrombus, ILT.
Ah, yes, the ILT. It's not just a passive bystander, it's biologically active.
How so?
Well, its formation activates platelets, increases oxidative stress, and leads to proteolytic injury protein breakdown.
Okay.
The thrombus itself actually recruits more inflammatory cells and cytokines. It's layered, with older clot against the wall.
And that's where the damage happens.
Right at that interface. An enzyme called plasmin activates matrix metalloproteinases, MMPs.
Those molecular scissors you mentioned.
Exactly. MMPs, particularly MMP9, MMP2, and MMP12, directly attack and degrade the elastin and collagen matrix of the aortic wall, weakening it.
So the clot contributes directly to the weakening.
It does. And the more clot burden there is, generally the faster the aneurysm grows.
And it affects the wall underneath.
Yes, ILT is associated with wall thinning, loss of medial smooth muscle, elastin degradation, and inflammation spreading into the outer adventitia. Possibly because the wall under the clot becomes hypoxic, starved of oxygen.
What about the adventitia itself, the outer layer?
It's involved too. Lots of inflammation there. Lymphocytes, macrophages, mast cells. You also see extensive fibrosis, scarring.
Is it objective?
Maybe to some extent it adds some thickness, but too much fibrosis can cause problems, like retroperitoneal fibrosis, where it encases other structures. And you also get neoangiogenesis there too.
It's a really active, destructive process then. Now, we mentioned family history. How strong is the genetic link?
Very strong. Heritability estimates are up to 70%. Genetics plays a major role, more so than in many other common diseases.
So having a first-degree relative,
Roughly doubles your risk, and that's independent of whether you have a known connective tissue disorder.
and it's not just the classic disorders like Marfan.
No. While conditions like Marfan, Loeys-Dietz, vascular Ehlers-Danlos definitely increase risks significantly, genome-wide association studies, GWSS, have found other specific gene locations, novel loci, linked to AAA risk in the general population.
Which could lead to better risk prediction.
Exactly. Things like polygenic risk scores are being developed based on these findings, identifying people at higher genetic risk before they even develop an aneurysm.
Fascinating. Lastly, under pathophysiology, those mycotic aneurysms, they're infection-based.
Yes. Caused by direct bacterial infection of the aortic wall. Usually bacteria like Salmonella, Staph, Strep, E. coli.
And they're dangerous.
Very. They tend to expand rapidly, high mortality. But thankfully, they're rare. Only a small fraction of all AAAs.
Is there any link between bacteria and regular AAAs?
There's a hypothesis that maybe bacterial colonization, either of the wall itself or the ILT, could play a role in the progression of typical degenerative AAAs, but that's still under investigation.
Okay, let's move to finding these things. Diagnosis. Most people don't have symptoms, right?
That's the usual situation, yes, asymptomatic.
But if they do have symptoms, what might they feel?
It's often quite vague, maybe a diffuse abdominal pain or back pain, often described as different from their usual aches and pains.
Like a new kind of pain.
Exactly. Some might feel a pulsating sensation in their abdomen. Very thin individuals might even see a pulse.
And they often have other related conditions.
Yes, it's common for them to also have hypertension, known atherosclerosis, a history of smoking.
What about on physical exam? Can a doctor feel it?
Sometimes. The classic finding is a palpable pulsatile mass, and crucially, it feels expansile, like it's pushing out in all directions with the pulse.
Where would they feel it?
Usually midline above the belly button, but the aorta can be tortuous, so sometimes it's off to the side or lower down.
Does size matter for feeling it? Or body weight?
Absolutely. Much easier to feel a larger aneurysm and much harder in someone with obesity. Sensitivity really varies.
And the doctor should check the legs, too.
Yes, always check for femoral and popliteal aneurysms at the same time, given the association.
So exam is helpful, but not definitive. Imaging is key.
Imaging is essential. Ultrasound is the workhorse for initial detection and screening.
Why ultrasound?
It's excellent for seeing the aneurysm, measuring the diameter accurately, plus no radiation, no contrast dye. Relatively cheap and available.
Downsides.
Can be limited by body habitus or bowel gas obscuring the view. And it's not great for detecting rupture, especially in an emergency if the patient hasn't fasted. It might miss up to half of ruptures.
Half. That's a big limitation in emergencies. What's better than?
CT scan. Computed tomography provides really clear images, very reproducible diameter measurements.
And with contrast. CTA.
CT angiography gives you a huge amount of anatomical detail. Calcification, thrombus, any blockages in other arteries. Essential for planning surgery, allows for 3D reconstructions.
Drawbacks of CT.
Radiation exposure, particularly if you need serial scans for surveillance. And the iodinated contrast can be risky for people with kidney disease.
What about MRI?
MRI and MRA, magnetic resonance angiography, are also very sensitive for detection.
Pros and cons.
MRI doesn't show calcification well, which can be important information. MRA uses gadolinium contrast, which has its own risks in kidney patients' nephrogenic systemic fibrosis.
Okay.
And metal implants can be a problem. But MRI's potential for dynamic imaging might be useful in the future.
And plain old angiography. Sticking a catheter in.
Not really used for screening or surveillance anymore. It's invasive, usually reserved for detailed planning right before an intervention, or for the intervention itself, like embolizing small arteries.
Okay, so ultrasound for screening mostly, CTA for detailed diagnosis and planning. Let's talk screening then. Who gets checked?
Well, the guidelines vary a bit. Different organizations, different countries. They're based on the big screening trials, evidence quality, cost effectiveness.
What are the main points of discussion?
Things like the best starting age, which specific risk factors matter most, and a big one historically was whether to screen women.
Why the debate about women?
Primarily because the original large screening trials included very few women, so the data just wasn't there initially to make strong recommendations. The U.S. didn't recommend routine screening for women for a long time.
But that's changed, given their higher rupture risk.
It has. Even though women get AAAs less often overall, their rupture risk is higher for a given size, and they live longer on average. So the thinking shifted screening women might actually be more cost-effective than we thought.
So what's the current recommendation, say, from the SVS?
The Society for Vascular Surgery now recommends a one-time ultrasound screen for both men and women, aged 65 to 75, if they have ever smoked.
No.
They also recommend it for first-degree relatives in that age group. Treatment thresholds still differ by gender, though.
And ways to refine screening for women are being looked at.
Yes. Using something called the aortic size index, basically adjusting the diameter for body size, might be a better predictor for women. That could improve future guidelines.
What about follow-up? If screening finds a small aneurysm, how often do you recheck?
That's another area with some debate. If someone has a normal screen, the risk of them developing a large aneurysm later is relatively low, but not zero.
Okay.
A meta-analysis looked at stratifying follow-up based on the initial size found.
What did it suggest?
Different intervals. For example, if it's 3.0 to 3.9 centimeters, maybe you recheck every 3 years. 4.0 to 4.9 centimeters, check yearly. 5.0 to 5.4 centimeters every 6 months.
And the SVS adopted those?
Yes, they're in the current guidelines, though the recommendation level is considered weak, meaning the evidence isn't super strong yet.
How do these SVS recommendations compare globally?
There are variations. Europe recommends screening all men at 65, but not necessarily female smokers. The UK screens all men at 65. Canada screens men 65-75 and selectively screens high-risk women. AACC have slightly different age ranges again.
So generally similar thresholds for treatment, but some differences in who gets that initial screen.
Exactly. Particularly around women and other risk factors besides smoking, it's still evolving.
Okay, so an aneurysm is found at small, below the treatment threshold. What about medical therapy? Can pills slow it down?
That's the million-dollar question. Currently, medical management for small AAAs is mostly about risk factor control.
Meaning?
Stop smoking. Control blood pressure. Manage cholesterol. General cardiovascular health.
But no specific drug to stop the aneurysm growing.
Not proven yet. Lots of things looked promising in animal models, statins, ACE inhibitors, beta blockers, even certain antibiotics like doxycycline.
But they didn't pan out in humans.
Largely no. The effectiveness just hasn't been clearly demonstrated in large human trials.
Oh, that's quite disappointing.
It is. Right now, the only things proven to reduce the risk of an AAA progressing to rupture are smoking cessation and good blood pressure control. Especially important for women, given their higher risk.
Why the disconnect between animal models and human trials?
It's complex. Maybe the animal models aren't quite right, don't fully mimic the human disease. Maybe we still don't understand all the nuances of human AAA progression. Or maybe the human trials weren't designed perfectly or big enough.
What about exercise? Should people with small AAAs avoid it?
No, generally the opposite. Studies show moderate exercise is well tolerated. It doesn't seem to significantly increase aneurysm size or rupture risk over several years. Patients should be encouraged to stay active.
Beta blockers were mentioned. Any effect?
They looked good in animals and early small human studies, but bigger, more recent randomized trials haven't shown they significantly reduced AAA growth. Even tight blood pressure control with propranolol didn't seem to slow expansion.
What about ACE inhibitors? Other blood pressure drugs?
Similar story. Some early positive hints from small studies, but larger trials like the UK one refuted that and even suggested ACE inhibitors might slightly increase growth.
So no specific BP drug helps the aneurysm itself.
Doesn't seem so. But good blood pressure control overall and statin use do help reduce the patient's risk if they eventually need surgery, makes the operation safer.
Doxycycline, the antibiotic.
Yeah, it inhibits MMPs, those wall-degrading enzymes. Worked in animals, but a big recent human trial. No significant reduction in AAA growth compared to placebo.
Statins, cholesterol drugs.
Again, promising in animals, but human RCTs haven't shown these slow growth. The UK heart protection study found statins didn't reduce the need for AAA repair, though they did reduce other major cardiovascular events.
And antiplatelets to reduce the clot.
Reduced expansion in rat models. But no human trials have directly linked antiplatelet use to slower AAA growth.
So the take-home is, no magic pill currently exists to reliably slow AAA growth.
That's the unfortunate reality right now. Focus is on risk factors. Stop smoking, control blood pressure. Research continues, hoping for better translation from lab models in the future.
Okay, so when do you intervene? What are the indications?
The main indication is size. Generally, elective repair is recommended at 5.5 centimeter diameter for men.
And smaller for women.
Yes, 5.0 centimeters for women, reflecting their higher rupture risk at smaller sizes.
What about aneurysms between, say, 4 and 5.5 centimeters?
Prevalence is considered safe for compliant patients in that range, based on the UK small aneurysm and ATOM trials.
But many end up needing repair eventually.
Yes. In the ATOM trial, over 80% of those initially watched in the 5.0, 5.4 centimeter range eventually had surgery. Many in the smaller groups did too over time. Surveillance often delays rather than avoids repair.
Are there reasons other than absolute size to intervene earlier?
Yes. Saccular aneurysms, because of their shape and higher risk, might be repaired sooner. Also, signs of instability, like dissection within the thrombus, or maybe a fracture in the calcification of a saccular one.
But just repairing electively below 5.5 centimeters doesn't improve survival.
Correct. Compared to watchful waiting until they hit the size criteria, early elective repair for asymptomatic AAAs, 5.5 centimeters, hasn't shown a survival benefit.
What about aneurysms that are causing symptoms or have ruptured?
There's no specific size cutoff then.
Well,
Ruptured AAAs need emergency repair, period.
and symptomatic ones.
They need urgent repair too, though sometimes there's a brief window to stabilize the patient medically first if possible. But basically, if they're symptomatic or ruptured and the patient can tolerate an operation, intervention is offered.
It sounds like a complex decision, weighing surgical risk versus rupture risk.
It absolutely is. You're balancing the immediate risk of the operation against the future risk of rupture and death. You have to consider the aneurysm factors: size, growth, shape, and the patient factors, overall health, life expectancy, their own preferences.
And then there's the choice of how to repair it. Open versus endovascular.
Right. Another critical decision point. Long-term mortality seems pretty similar between the two after about 2 years.
But short-term.
Endovascular repair, EVAR, generally has lower perioperative mortality and complication rates. It's often preferred, especially in patients with significant comorbidities who might be higher risk for open surgery.
Does open surgery still have a role?
Definitely. In younger, healthier patients, the long-term durability of an open repair might be favored. Also, if the patient's anatomy isn't suitable for an endograft, or if they have certain connective tissue disorders where long-term graft complications might be a concern.
Are there tools to help make these decisions? Risk calculators.
Yes, they're becoming increasingly sophisticated. Using data from large registries, we can get better patient-specific risk estimates for procedures.
Any specific examples?
The VSG&E Risk Index from the Vascular Study Group of New England is a good one. It's particularly good at predicting cardiac risks after vascular surgery and is recommended by the SVS.
What kind of things do these calculators look at?
For open AAA repair, the SVS calculator considers kidney function, creatinine, lung disease, COPD, where the clamps and grafts will be placed, BMI, race, prior heart procedures, stress test results, heart failure history, age. Quite comprehensive.
Gives a much clearer picture of the individual's risk profile.
Exactly. Helps guide that shared decision-making process.
Okay, finally, let's look ahead. Future directions. What's on the horizon?
Well, endograft technology keeps evolving. Better devices, treating more complex anatomies.
But beyond the devices.
The really exciting stuff comes from our deeper understanding of the biology, the genetics, the molecular pathways. That's where future breakthroughs in diagnosis and therapy will likely come from.
Like what specifically?
Maybe better biomarker screening. Not just finding aneurysms, but maybe identifying ones that are actively progressing or about to rupture by looking at profiles of proteins or gene activity in the blood.
Measuring breakdown products.
Exactly. Like measuring circulating peptides from elastin or collagen degradation.
That sounds potentially powerful. What of the genetic side?
With cheaper sequencing, we might see more preemptive genotyping, using those polygenic risk scores we talked about to identify high-risk individuals much earlier, maybe even before screening age, and tailoring surveillance. Clinical integration seems likely soon.
Could imaging get smarter too?
Hope so. Moving beyond just maximum diameter. Recognizing subtle signs on CT, like the crescent sign suggesting impending rupture. Better understanding how calcification affects risk. Is it protective or not?
And imaging inflammation.
Yeah, potentially using advanced MRI techniques or nuclear imaging, scintigraphy, to actually visualize inflammatory cell activity within the aneurysm wall. That could be a marker of instability.
But the biggest prize would be effective medical therapy, right?
Oh, that's the ultimate goal. Finding drugs that can actually halt or reverse aneurysm growth, especially for smaller ones or for patients who just can't undergo repair.
What are the current targets for that research?
Key areas include interrupting that inflammatory cascade, blocking MMPs, cytokines, trying to suppress that abnormal blood vessel growth, neoangiogenesis, and minimizing the oxidative damage coming from the thrombus.
Lots of potential avenues then. It's clearly a field that's still moving forward.
Absolutely. Our understanding is constantly improving, leading to better detection, better management, and hopefully better prevention in the future.
Well, this has been an incredibly thorough deep dive into aortoiliac aneurysms, thanks to the insights from Rutherford. We've really covered the spectrum.
We have. From the definition and who's affected, through the risks, the complex biology, how we find them, screen for them, and treat them.
Key takeaways seem to be understanding those risk factors, especially smoking, the importance of screening in the right groups,
And appreciating the advances in repair, but also the current limitations of medical therapy.
So let's leave you, our listener, with a final thought. We talked a lot about the strong genetic component and the hunt for biomarkers. Thinking ahead, what could personalized screening and maybe even early targeted interventions look like for someone who knows they have a strong family history or carries specific genetic risk markers?
It raises fascinating possibilities, doesn't it? Definitely worth keeping an eye on the research into genetic risk and vascular health advancements.
Thanks for joining us for this deep dive.